A baby is born prematurely at 28 weeks. At first, she seems stable, but within 48 hours, she starts breathing rapidly, tiring easily during feeds, and has a bounding pulse. When you listen under her left collarbone, you hear a loud continuous sound like a machine running inside her chest. What's going on? This baby has patent ductus arteriosus, or simply PDA. What is PDA? PDA is a congenital heart condition where a normal fetal blood vessel, the ductus arteriosus, fails to close after birth. This leaves an abnormal persistent connection between the pulmonary artery and the proximal descending aorta. Why does the vessel exist and why it stays open? Before birth, a baby doesn't use its lungs. Blood bypasses the high-pressure fluid-filled lungs through ductus arteriosus, sending oxygen-rich blood straight from the pulmonary artery to the descending aorta. During fetal life, two main factors keep this vessel open: low oxygen levels, a natural hypoxic state in the womb, and high prostaglandin levels, which keeps the smooth muscles relaxed. Normally, at birth, when the baby takes its first breath, the oxygen levels rise and the prostaglandin levels drop, and the ductus will close within 24 to 48 hours. What happens if it doesn't close? That's when we get PDA. According to the causes, we can classify PDA into three groups: premature infants, term infants, and syndromic children. In premature infants, their vessels haven't matured enough to respond to oxygen. Term infants, it's mainly due to structural anatomical defects, for example, lack of smooth muscles. And syndromic children is mostly seen in babies with conditions like congenital rubella. After birth, the blood pressure in the aorta is much higher than in the pulmonary artery, both during the systole and diastole. Because the fluid follows the path of least resistance, blood gets forced back from the high-pressure aorta into the low-pressure pulmonary artery. This is called a left-to-right shunt. Because the blood flows continuously through both the phases of the heartbeat, it creates that classic continuous machinery-like murmur heard below the left clavicle. Excess blood goes into the lungs and drains back into the left atrium and the left ventricle. Over time, the constant volume overload causes left ventricular dilatation. What happens if it is untreated? Excess blood flow damages the lung vessels, leading to pulmonary hypertension. Eventually, lung pressure exceeds the systemic pressure and the shunt flips to right to left. This is called Eisenmenger syndrome. Eisenmenger syndrome is a late complication and characterized by differential clubbing and differential cyanosis. Because the open ductus sits in the descending aorta after the branches supplying the arms and the head and the arms get fully oxygenated blood, therefore remaining pink, and the lower limbs receive deoxygenated blood, turning into cyanotic. This unique hallmark is known as differential cyanosis and differential clubbing. How do you spot this on a wardroom or in your exams? Look out for 4 hallmark signs. Number 1. The classical sound, a continuous machine-like murmur that roars right under the left collarbone. Unlike most murmurs, this one never rests. It hums through both heart contraction and relaxation. Second, the pulse. Bounding or collapsing pulses paired with a wide pulse pressure. This happens because the blood instantly leaks out of the aorta into the lungs during diastole. Third, the chest. A hyperdynamic, heaving precordium where you can literally see the heart fighting against extra volume. Fourth, the struggles. Babies with significant shunts tire out fast. Watch for rapid breathing, sweating during feeds, and poor weight gain. When PDA is on your radar, here is how you work it up. Pulse oximetry is usually fine early on, but keep an eye for differential cyanosis, where the upper body stays pink while the lower body turns blue. That's a sign pulmonary pressure has spiked, reversing the shunt. Quick checks. An ECG might show left-sided heart strain, and a chest X-ray will reveal an enlarged heart shadow with congested wet lungs. The gold standard. You cannot lock in a definitive diagnosis without a transthoracic echocardiogram with a Doppler. How do we treat it? Treatment depends on the age and the patient's specific heart anatomy. In preterm infants, when the baby matures, the defect will close. If it doesn't close, we have to do medical closure by using NSAIDs like IV ibuprofen or IV indomethacin. These drugs inhibit COX enzymes, dropping prostaglandin levels so the vessels clamp shut. Remember, you can use paracetamol if NSAIDs are contraindicated. What about in-term infants and older children? In this case, medications won't work since their vessels are already maturing. If the PDA is small and asymptomatic, they are monitored as they may close spontaneously in the first year. If the PDA is large or symptomatic, they require transcatheter closure using coils, plugs, or surgical ligation. Remember, before we even think about closing a PDA with medications, there's a critical rule every physician must follow. You must first screen for duct-dependent circulation. In some congenital heart defects, the baby's pulmonary blood flow depends entirely on keeping that ductus open to survive. If you close this ductus in these babies, it can be fatal. These duct-dependent lesions fall into three main groups: left-sided or systemic flow-dependent, right-sided or pulmonary flow-dependent, or other complex defects. Left-sided includes severe coarctation of aorta, severe aortic stenosis, and hypoplastic left heart syndrome. Right-sided includes tricuspid atresia and pulmonary atresia. Other complex defects include such as transposition of the great arteries. You may be wondering, how do we screen? It's simple and non-invasive. We perform pulse oximetry screening by checking the oxygen saturation in both the upper and lower limbs. If there's a difference of more than 10% between both the limbs, we must suspect duct-dependent circulation. Instead of closing the ducts, we do the exact opposite. We give a continuous IV infusion of alprostadil, which is prostaglandin, to force the ductus to stay open until emergency surgery can be performed. If this helped making your study easier, smash the subscribe button. Let me know what clinical topic we should conquer next, and I'll see you in the next video.